I'm a respiratory physician. I'm sitting in a room full of intensivists, so I feel slightly fearful, I have to say. And we were saying earlier that intensivists and respiratory physicians do NIV differently. I'd like to say I don't think there's a right answer, but I know what you're thinking. I'm thinking it too. So I'm just going to be talking about the indications, how to do it, or how we tend to do it within respiratory medicine. I'm going to focus on hypercapnic respiratory failure, just simply because Louise has given such a comprehensive overview of the current evidence. The evidence for acute hypercapnic respiratory failure in NIV is old, so we need to be focusing really more on quality rather than trying to find new evidence that it works, because it works. So acute hypercapnic respiratory failure, in particular exacerbations of COPD, are important. There's significant mortality, significant readmission rate, and then there's an extremely poor long-term prognosis. It doesn't matter where you look, your prognosis within a year to 2 years the mortality is 50-odd%, whether it's in the States, whether it's in the UK, whether it's in the Far East. And pH is important in determining the prognosis. We see in some really quite old studies now that I'm hoping that most of you won't have been around to see these studies, actually. It's just possible, actually, that so they may be new to you, but they're really quite old. But of course, the NIV success or failure is very much dependent on the trajectory of your pH during non-invasive ventilation, and pH in the early studies was very much the only indicator of ICU admission. So is there any point in patients who aren't acidotic to ventilate? And again, this is not something we think about, but it's always good to just go back and see why we don't ventilate patients who are hypercapnic, but present acutely with a normal pH. And it's because it has no difference on the length of stay. It does improve breathlessness more quickly, but there are no physiological benefits. But of course, in acidotic patients, there's reduction in pH, there's an improvement in dyspnea, reduction in length of stay and intubation rates, all data that you're familiar with, but it's important to note that the vast majority of NIV in the UK, rightly or wrongly, occurs on the general wards. And it's important to remember that in the original study, last in 2000, that the benefits of ward-based NIV are very much in favour of those patients with a mild acidosis with a pH greater than 7.3, not those with the more severe pH. Now, of course, has resource implications, but we'll talk a little bit about how we manage, or how we are currently managing, patients with mild and severe respiratory acidosis later. Again, old data, reduction in mortality, reduction in need for endotracheal intubation, reduction in length of stay. The data are less prominent for obesity-related respiratory failure, and about 40% of the patients we now set up on the Lane Fox unit on home non-invasive ventilation have got obesity, either with or without COPD, and the majority of those patients will come to us after an acute exacerbation, acute acidotic episode. The data are pretty scant, and there are no real randomized controlled trials in patients with obesity hypoventilation syndrome. But again, this relatively old study shows that the outcomes in terms of readmission risk are similar to COPD, but patients with COPD have a significantly higher mortality than those with OHS. And similarly, patients with obesity hypoventilation and COPD, so the COPD-OSA overlap syndrome, have a better prognosis than those with COPD alone. Now, if you see a patient with an FEV1 greater than 1 with hypercapnic respiratory failure, have a look at their BMI, because they've almost certainly got some sleep disordered breathing as well, contributing to their respiratory failure, and that's important to address too. The third important indication for non-invasive ventilation here is neuromuscular disease. Patients are surviving longer with congenital myopathies. They're presenting to our emergency departments more frequently, mainly because of people like us keeping these patients ventilated and trying to maximize their quality of life. And as you can see, with Duchenne muscular dystrophy, for example, you see a marked drop-off in the FVC around about the age of 18, and it's around about that age that you might expect to see these patients presenting to the emergency department, although increasingly with better transition services between paediatrics and adult care, those acute decompensations are less common. We transition patients much earlier onto NIV before they run into problems. But once you ventilate these patients with neuromuscular disease, Duchenne muscular dystrophy, you improve their prognosis significantly, mainly through improving their respiratory muscle function. So this is before they're ventilated, and this is afterwards, home ventilation that is. Their CO2 improves, and the time they spend with low SpO2 also significantly improves. So these patients will decompensate when they have pneumonia. And the criteria now for ventilating these patients, you should try and for both obese patients and for patients with neuromuscular disease, if they're somnolent and they're in respiratory distress, regardless of their acidosis, it's worth ventilating them acutely. And I would very much advocate that these patients in particular do not receive, if they're not acidotic but they're struggling to breathe, I think these patients in particular, I don't think benefit from high flow. There's no evidence, but these patients have got primary pump failure, and what they need is a ventilator. I'm going to skim over really the evidence for acute cardiogenic pulmonary edema and NIV. Again, very old data demonstrating that mortality and intubation risk are improved. And I think, Louise, you've described in some detail acute hypoxemic respiratory failure and the benefits of NIV. The only thing I'd mention, actually, is this trial from Fratt and colleagues from 2016 that you can see on the far right, whereas earlier data might have indicated some benefits to non-invasive ventilation in patients with immunosuppression. This study here shows that intubation risk is lowest with high flow, and in fact, NIV was both a risk factor both for intubation and for mortality. Once again, for these following slides, I think Louise has covered these in much more detail and better detail than I could possibly do. So I'm going to skip through those, particularly with respect to time. So how then do we set up non-invasive ventilation? We've talked about the indications. What about the contraindications? Well, the absolute contraindications in the BTS guidelines indicate that we should avoid patients with severe facial deformity, facial burns, and fixed upper airway obstruction. But then what about the relative contraindications? And it's interesting to note here that an undrained pneumothorax is not considered to be a contraindication in the latest BTS guidelines, which admittedly from 2016. I would not advocate starting non-invasive ventilation on a patient with undrained pneumothorax. Hopefully that'll be included as a subsequent point. So what about those patients with a GCS less than 8? Should they receive non-invasive ventilation? And increasingly, I think they do. And there's reasonable evidence that if patients have got hypercapnic encephalopathy, that they do benefit from non-invasive ventilation, and the outcomes are excellent. And NIV failure in these patients are associated with a failure of the GCS to improve, so patients without hypercapnic coma don't improve. So it's very much a relative contraindication. So then we come to setting up acute NIV, and this is where I think there is a discrepancy between highly, intensely supervised non-invasive ventilation in very sick patients on the ICU versus the patient who's coming in through the emergency department, who's perhaps not for intubation, who then gets set up on the general ward or on the acute medical ward. I think it's important to discuss because you see these patients and you advise on them and sometimes take them to critical care. It's become a routine part of clinical practice, but the quality of delivery can be variable. And as early as 2008, we saw the opposite of what was seen in the trials, that patients who are acidotic who received NIV did worse than patients who are acidotic and didn't receive NIV, which is extraordinary. The NCPOD study, I'm sure many of you are familiar with, looked at, I think it was around 600 patients with acute hypercapnic respiratory failure or who required acute non-invasive ventilation, and assessed essentially how well we were doing it. And a goodly proportion of these patients were in hypoxemic respiratory failure, who classically would be treated, I think, in an intensive care environment. And pneumonia, patients were treated with pneumonia in about 12% of cases. The crux of this study, in my view, and I was a reviewer for this study, as I'm sure many of you were, was that in a quarter of cases, patients were deemed by reviewers to have received unacceptable or poor quality of care, which is extraordinary for a condition that affects perhaps 1 in 25 acute admissions through the emergency department. So about 1 in 5 acute exacerbations of admissions or exacerbations of COPD. About 1 in 5 of those will have hypercapnic respiratory failure. So the fact that we're failing a quarter of these patients is an extraordinary admission of failure, I think, and much has been done to improve things. So, and again, the trials will say that the mortality is around the mid to high teens, but the mortality here was 35%. A third of patients received NIV 24 hours, more than 24 hours, after the recognition of acidosis. Looking at the settings, an extraordinary number of patients had no increase. A fifth of patients had no titration of their IPAP after their initial settings. And 42% were deemed to have received inappropriate ventilatory management. The EPAP, I think you could argue, and I have a particular bugbear about how we set EPAP in patients with COPD and obstructive sleep apnea. But nonetheless, a lot of patients received an inappropriate level of EPAP, inappropriate high level of EPAP. So how do we get NIV right? Well, we need to find the right patient, so acidotic but not too acidotic. In type 2 respiratory failure is the main indication. At the right time, within the first hour. In the right environment, so if you've got severe acidosis, you should really be considered to be in critical care. I'm sorry to shunt all these patients your way, but that's what the evidence shows. And those with mild acidosis can be looked after on the general ward, but which general ward? And some elderly care wards have got superbly trained nurses for NIV. Some respiratory wards may not. And so this is very much service specific. And so the evidence and the improvements surrounding NIV now are much more about service improvement and quality improvement than about generating new data. I hope you can see that. And it needs to be delivered by the right people. So again, 45% of patients in the NCPOD study had their NIV managed. So life support managed by non-specialists. I hope you wouldn't expect me to come along to the ICU and start fiddling with the renal replacement therapy. I might. I did do during COVID, actually. So what is it that we need to deliver good NIV? And this is an excellent editorial from Mark Elliott in Respirology a couple of years ago. So it's a mix of the academic, the clinical, and education. But on top of that, you need the diagnostic skills, the leadership across the professions, not just medics, not just nurses, not just physios, but across the multidisciplinary team. It needs to be linked in with chronic disease management. There needs to be obviously an understanding of physiology, about the mechanics of NIV, but also an understanding of sleep physiology as well. And towards the sicker end of the spectrum, we need palliative and end-of-life care skills too. Do we deliver that in a consistent way with our patients coming through the door, the 75-year-old with just another acute exacerbation of COPD? And I'm not certain that we always do across the board. So how do we start? Well, we communicate with the patient. We're fortunate in that most of our patients are awake. We make sure that we have a treatment escalation plan. We choose the right interface mode settings. So what about the mask? Well, most NIV in the UK is not done through helmet. Luigi, I wish it were. I wish there was more. But two important things to note: skin breakdown, and also make sure, please, that you make sure in a single limb circuit there's a vented mask. We have SUIs every year relating to even at St Thomas's, I think, Luigi. There are the nasal bridge sparing masks that can be used, and of course the helmet masks as well. I'm sure that's the wrong picture. I'm sure there's a mistake in that picture or something, Luigi. No. What about the initial pressure settings? Well, an understanding of the physiology helps. We need to know what the loads are on the respiratory muscle pump, the capacity and the neurorespiratory drive. So in COPD, you need higher EPAP, perhaps. In patients with a threshold load, you need a short TI for those patients who are hyperinflated. And with those patients with high drive, you need PSV mode rather than PCV. That's just to show that actually if you titrate the EPAP according to to optimize patients to minimize their expiratory flow limitation, then you minimize their work of breathing, their neurorespiratory drive. So patients with OSA-OHS may need greater support in terms of EPAP to overcome their upper airways obstruction. They have high elastance, they need a longer TI to inflate their lungs and maximize their tidal volume, higher IPAPs because of the increase of intra-abdominal pressure, and they too develop intrinsic PEEP. And similarly with the neuromuscular disease patients. So how do we predict NIV failure in acute respiratory failure? Well, you could refer to the 2005 study of Confalonieri, which looked at probability of NIV failure in exacerbations of COPD. But I have to confess, although supremely accurate, I think it's quite difficult pragmatically to look at that on a daily basis. What are the predictors of NIV failure in acute exacerbations of COPD across these multiple, now old studies? Well, I think the thing to look at really most of all is whether there's been an improvement in your physiology and the patient comfort and the patient's respiratory state after 1 hour. And that's reflected in this in 2017-18 NCPOD report. Give NIV early, give it in chronic obstructive COPD, and they have the best outcomes. Give it in mild to moderate respiratory acidosis, and give it appropriately in good time. There's a great new and very, very well validated risk prediction score, mortality prediction score called the NIVO, published in the ERJ just last year, which identified these 6 independent predictors of mortality. So consolidation, impaired consciousness, atrial fibrillation, severe acidosis, late acidemia, and underlying severe level of dyspnea. And you can categorize these patients if they've got a high NIVO, very high NIVO score. The mortality is 80% at 90 days. And the great thing about this score is you can assess their prognosis before you've even given the NIV. Again, I'm not going to dwell too much on hypoxic respiratory failure. Suffice to say that delaying intubation is bad for you. I'm going to skip through these in the interest of time, because I think, once again, I think, Louise, you've covered the hypoxemic respiratory failure area very, very thoroughly. So look, in summary, the issues around acute NIV and hypercapnic respiratory failure now are not around new data, how to do things in a novel way, but to do what we know works in a manner that is safe and efficacious, not just for the patients in specialist areas or specialist units or in ICUs, but also across the board from the emergency department all the way to discharge. And to administer it in a timely way with the appropriate settings, it remains a life-saving mode of ventilation. We should focus on quality of delivery, and that includes more research, better clinical education, and a better understanding of the process through which patients go as they receive NIV. Understanding the physiology is undoubtedly important, and the early identification of the high-risk patient is important to avoid or expedite the need for escalation of care. I appreciate that's been quite a brisk romp and some quite old data, but I hope you appreciate really now it's about quality of care rather than generating new data. Thanks very much.